Okay, let's think about something really tough for a moment. Facing a terminal illness, maybe getting a cancer diagnosis, it just unleashes this flood of emotions, doesn't it? Fear, grief over everything you're losing, feeling like you have no control, and that constant worry about pain.
Yeah, absolutely. And it's not just the person who's ill. It hits families, caregivers, everyone involved really hard.
It really does.
And, nurses are right there day in, day out providing care. But what's interesting and maybe a bit surprising is that our sources show many nurses still feel, well, uncomfortable around death and dying.
Really? Despite being professionals in that setting.
Yes, and that discomfort, it's understandable, but it can, unintentionally affect the kind of care they give.
That makes you wonder then, how can we actually do better? How can we support people and their families when they're going through something so difficult?
Yeah.
So that's what we're diving into today. We're going to look at our source material and try to pull out the most important insights, figure out the main challenges, and crucially, what the recommendations are for improving care. Right, so where do we start? What are the biggest hurdles based on what we've looked at?
Well, a really central theme is fear. There's this deep, almost primal fear of death itself, the unknown, but also the fear of just unbearable pain, especially with something like cancer. That word often conjures up images of, suffering, losing your autonomy.
That's loaded with baggage.
It really is. And it just highlights how vital it is for healthcare professionals to really get that, to understand those deep fears patients are grappling with.
It's like the diagnosis itself becomes a source of suffering even before anything else happens.
Yeah.
And linked to that, there's a whole issue of communication, isn't there? How information gets shared or, well, sometimes not shared.
Exactly. There's a history, in medicine of sometimes holding back the full picture, the diagnosis or the prognosis from patients. Maybe the intention was to protect them, but often it just created tension, mistrust even, within families or between the patient and the doctors and nurses.
I can imagine. That puts nurses in a really tough spot, doesn't it?
Oh, absolutely. They often want to be open, to be compassionate, but they might feel, well, stuck, limited by what the doctors have said or maybe what the family wants, even if it conflicts with what the patient seems to need.
Wow. That sounds incredibly stressful, just trying to navigate that.
It is. It takes a huge emotional toll. You're highly involved, you care, but you can't always communicate openly. Our material really underlines this point. We need better support systems for nurses, places where they can actually process these feelings. It's not just about their own well-being, though that's crucial. It directly impacts the care they can give.
Okay, so we have the patient's fear, the family's stress, the nurse's emotional burden. It sounds like grief is just woven through this whole experience from start to finish.
Yeah, grief is absolutely central. And a key thing to grasp is that grieving isn't some neat step-by-step process. The Kubler-Ross model, denial, anger, bargaining, depression, acceptance. People know those stages, and they can be a helpful way to start thinking about common reactions.
It's not like a checklist. Right.
Definitely not. It's really critical that caregivers don't treat it like that. Everyone grieves differently. It's complex, it's messy, it's unique to each person.
And it doesn't just pop up at the very end, does it? I mean, it sounds like grief starts way earlier.
Oh, much earlier. Often right from the diagnosis, the person starts grieving the life they thought they'd have, the future plans. And that grief, it kind of ebbs and flows, but it continues. Sometimes long after the person has died, and it affects the whole family, obviously, and we really need to think about children, too.
That's such an important point. It's easy to think kids are somehow shielded, but they pick up on so much, don't they?
They really do. There is often this instinct to protect them, to keep the harsh realities away, but they are deeply affected when someone they love is seriously ill or dies. How we handle that with them matters hugely for their emotional health down the line.
And the sources also pointed out that some groups might face sort of extra challenges in grieving.
Yes, that came through. For instance, bereaved men, especially if they're younger widowers, they often don't have the same kind of social support networks that women might have access to more readily.
Right. Less likely to talk about it, perhaps.
Perhaps. Or the networks just aren't there in the same way. And this can make their grief feel more isolating and makes dealing with all the practical stuff harder, too.
That makes a lot of sense. Society's expectations can be tough. And you mentioned the LGBTQ plus community as well.
Yes. Individuals in the LGBTQ plus community might face added layers of stress. Things like social stigma, or maybe their relationship isn't legally recognized in the same way. That can create real barriers during caregiving and bereavement. It really underscores the need for support networks that understand these specific issues.
Okay, so we've touched on fear of death, communication issues, the impact on nurses, the whole complexity of grief, and another huge piece, which you mentioned right at the start, is pain.
Yes, pain. It's always a major concern. And it's vital to remember it's not just physical, there's a massive psychological element. Just the fear of pain can make the actual suffering much, much worse.
But the good news is,
The good news, and this is a really crucial takeaway from our sources, is that pain management has come a long way. Pain is actually much more controllable now than many people realize.
that's such an important thing for people to hear. I think that image of inevitable, awful pain is so ingrained.
It is. And that's why nurses need to assess pain holistically. It's not just about asking, rate your pain from 1 to 10. It's about considering, cultural background, ethnicity, how someone individually experiences and expresses pain.
Because it varies so much.
Hugely. What one person calls discomfort, another might feel as agony. You have to be sensitive to those differences.
Right. This gives us a really good picture of the core challenges. It's complex stuff. Our sources also tackled some direct questions, kind of like a spicy Q&A section, which I found really helpful for clarifying things. The first one was basically, why is it still so hard to talk openly about death and healthcare? What did the material suggest?
Yeah, it seems to boil down to a few things. One is just, enduring societal taboos around death. It's still uncomfortable for many people. Then there's the fear, a very human fear, of upsetting patients or families by being too blunt.
You don't want to take away hope.
Exactly. And traditionally, medicine has sometimes focused more on the facts, the clinical side, maybe less on the emotional experience. Plus, as we said, nurses can feel caught, wanting to be honest, but feeling constrained.
It really points to needing a shift in culture, maybe even in training, which kind of leads to the next question. How can nurses get more comfortable dealing with death so they can provide better support?
The sources pointed to a few key things. Support groups are really valuable places where nurses can actually talk about their own experiences and feelings without judgment. Also, having managers who understand and are supportive makes a big difference, creating that safer environment. And then there's the individual level, encouraging nurses to sort of reflect on their own beliefs and anxieties about death. That self-awareness can really strengthen their ability to connect with patients.
That makes sense. Support them so they can support others. Okay, another question was about misconceptions around pain. What's the biggest one?
The absolute biggest one is that severe pain in terminal illness is just unavoidable, that it's something you just have to endure. And as we discussed, that's often just not true anymore. Modern pain management can be incredibly effective, both for physical and psychological suffering. It can make a huge difference to quality of life.
It's such a vital message. It really changes the perspective. Then there was the sensitive topic of involving children. How should they be included when a family member is dying?
Yeah, the main point there was really about not overprotecting them by excluding them completely. Of course, you tailor it to their age and understanding, but involving them appropriately actually helps them process grief more healthily. It aids their emotional development. Keeping them totally in the dark often just creates more fear and confusion for them.
Finding that balance, I suppose. Not overwhelming them, but not shutting them out either. Okay, and the last Q&A point was on those unique challenges for bereaved men. What stood out?
Several things, really, that often link together. Those societal expectations about men being strong and not showing vulnerability. They often have fewer close friends or support networks to lean on compared to women.
Right.
And then they might suddenly be juggling everything grief, maybe being the sole parent, financial pressures. It can lead to real isolation and intense stress.
Yeah, a specific kind of vulnerability that maybe isn't always recognized.
Okay, so we've looked at the challenges, dug into some key questions. What about solutions? What recommendations came out of the material for actually improving care?
Well, they really flow logically from the problems.
Yeah.
First and foremost, really pushing for open, honest, and compassionate communication between everyone, patient, family, doctors, nurses, getting everyone on the same page, reducing that mistrust and isolation we talked about.
Makes total sense. Clear communication is key. And then for the nurses.
Absolutely. Building on what we said, establishing proper support systems, dedicated spaces, maybe specific training to help them handle their own grief, their own fears about mortality. It helps them and the patients. And for grief itself,
recognizing it's not one size fits all, moving away from rigid stage models and tailoring support to the individual. What does this person need right now? And making sure that includes support for children too.
And with pain management.
Being culturally sensitive. Understanding that how people experience and express pain varies, so assessment and management need to respect that diversity.
Okay. And for those groups facing extra hurdles.
Developing targeted support. Networks specifically for, say, bereaved men or for LGBTQ plus individuals facing end-of-life issues, giving them spaces where their unique challenges are understood.
Right. And finally, the family.
Yes, making it easier for families to be involved in
Right.
the care, in the grieving. Fostering that connection helps everyone cope better emotionally, especially the kids.
So when you boil it all down, it sounds like improving care for the dying isn't just about, better medicine, though obviously that's vital. It's also fundamentally about emotional intelligence, isn't it? Cultural awareness and just real human connection.
That sums it up perfectly. It requires both. And nurses, they're right at the heart of making that connection happen. But, and it's a big but, they need the right tools, the right training, and crucially, the right support themselves to be able to do that effectively.
It really does make you pause and think, doesn't it?
Yeah.
About how important open conversations about death and dying are. Not just in hospitals, but, in our own families, our communities. How could really understanding these challenges and these recommendations we've talked about help all of us create more compassionate, more supportive experiences when people face the end of life? Definitely some food for thought there.